Okay, hi everyone, good morning. Like Dr. Cedar mentioned, my name is Inna Hussein. I am an associate professor in the Department of Otolaryngology and section head of laryngology. So today I'll be speaking to you about minimally invasive treatment of subglottic stenosis. This is something that I am both clinically and research-wise very interested in, and so it's a large part of my current practice. I have no disclosures. So when we're talking about subglottic stenosis, what we're talking about is a narrowing in the area of the subglottis, which is actually technically a part of the larynx. It starts almost immediately below the infrachordal or free margin of the vocal folds and usually extends to the inferior portion of the cricoid. Often though, when these patients present, there is some involvement more distally to the upper trachea. And in this area, it can also grow caudally up to the level of the glottis or the vocal folds, which when it can present with both a narrowing in this area with mobile vocal folds, or if there is growth upwards, you can actually have some vocal fold paresis or paralysis, as well as posterior glottic stenosis that makes it a little bit more complex to treat. Classically, we think of this as a condition that develops secondary to intubation trauma or prolonged intubation, and it's estimated to occur in about 1 in 200,000 intubations. Subglottic stenosis can occur for other reasons as well, including autoimmune conditions such as granulomatosis with polyangiitis, and another condition called idiopathic subglottic stenosis that I'll be mentioning in just a few slides. When dealing with subglottic stenosis, the main thing to kind of remember, kind of where my mindset is that I think of it as a chronic progressive inflammatory disease, and that's how I kind of customize my options for patients. Okay, so I just wanted to take a slide to mention, kind of as a patient advocate for something known as idiopathic subglottic stenosis. This is a rare condition, but we do see quite a bit of it here in the Midwest. This is a progressive inflammatory condition of the subglottis that's primarily found in Caucasian females and usually presents in the ages 30s to 50s. Progressive dyspnea on exertion is kind of the mainstay, and when the disease gets more severe, patients can present with inspiratory stridor, voice changes, cough, chronic throat clearing, and mucus issues. Usually they have no history of recent or prolonged intubation, and unfortunately this is often misdiagnosed as asthma. One study found that most patients were almost misdiagnosed for close to 18 months. As we know, a delay in diagnosis leads to disease progression. I always tell people, time is airway in these cases. And so trying to increase awareness about this condition so that we can catch some of these patients earlier. We call it idiopathic subglottic stenosis because we don't really understand why this occurs in the area of the subglottis. Classically, it was thought to be secondary to some sort of inflammation from GERD. Perhaps there was a hormonal component since it's predominantly occurs in females. It's been suggested that perhaps it's a form of limited granulomatosis with polyangiitis, but none of these kind of etiologies have really been consistent in the literature in terms of reviewing them. The most recent kind of thought process is that there's probably some sort of aberrant mucosal immune activation that occurs, and that the initial trauma is perhaps from a multifactorial type of process. And so there is some promise. There are doing more studies looking at IL-17A as possibly a target for future medical treatment for this. In terms of management for subglottic stenosis, we primarily think of this still as a surgical disease. We talk about endoscopic options, endoscopic dilations using a variety of different instrumentations. And for very severe cases, we talk about cricotracheal resection, like Dr. Stenson mentioned earlier. Medical management is often thought of more of an adjuvant type of thing, using things such as mitomycin C topically to help decrease scar recurrence. Methotrexate is really not used anymore, primarily, again, especially with idiopathic subglottic stenosis. Most of our patients are females, and there's a high toxicity rate with methotrexate. And then the use of corticosteroids kind of as an adjuvant therapy as well. So we'll talk a little bit about kind of minimally invasive options. So in this today's talk, I'll be talking kind of a little bit about endoscopic dilation and then some things I actually do in the office. So with regards to endoscopic dilation, being an ENT, the direct laryngoscopy is my friend, and this is how I access the area. So generally in terms of equipment, I will have my laryngoscope, I will have a variety of balloons, and there's various companies that make these, and then a variety of kind of what we call microlaryngeal instrumentation. We gain access to the kind of larynx through direct laryngoscopy, place this in suspension so that it can be a two-handed surgeon, and then depending on the severity of the disease, how thick the scar tissue is, may use microlaryngeal instrumentation, and even will use CO2 laser at times. So one of the things I do want to mention is endoscopic interventions are kind of the preferred initial route when treating these patients, but there are some patients that just aren't candidates for this. So this is an examination of a patient we brought to the operating room who does have a tracheostomy and was having difficulty phonating and capping. And unfortunately, what we found was a complete grade 4 stenosis. So when a patient presents in this situation, endoscopic intervention is nearly impossible just because there's no kind of patent lumen to try to kind of increase and open. The next slide I want to show you, though. So this is interesting. So this was a similar presentation. Aphonia, can't cap, has a trach. But this patient, when we took, has this very, very tiny pinpoint opening right in the middle. The difference between the first patient and the second patient, perhaps a week or two. So this is what I mean in terms of time as airway. So with the small patency, though, I was able to try a few techniques. So I just need some sort of lumen to try to increase. So in this case, I tried to use a suction to probe, used what's known as a sickle knife to try to incise some of the stenosis, give myself a little bit more working space, place a balloon to dilate, and create more patency in the airway. Okay. I always inject steroids in any sort of intervention as a way to try to trick the body into not re-stenosing. But here we were able, with that pinpoint, to create an airway where this patient could now phonate, and patient was eventually decannulated. So within a week or two, it would have been kind of really no endoscopic options, but thankfully this patient came in just right in the nick of time. Okay, so one big question that comes when managing and working with these patients, since this is a chronic progressive inflammatory disease, how can we manage these patients prior to needing these operative interventions? The reason this is important is, we know that the scar tissue in most patients is going to recur, and as it continues to recur, will cause progressive symptoms. Progressive shortness of breath affects your quality of life. It is not pleasant to wait until you are stridorous and can't breathe to have something done. And so the question was, is there something we can do to help these patients so that they're not in that kind of extreme doing well, and then all of a sudden not doing well and needing to go emergently to the operating room? So this comes kind of to the pathology. So what are we actually dealing with? Every time I have a subglottic stenosis patient for the first time, I always do an endoscopic biopsy of the tissue. And not unsurprisingly, it is always consistent with scar tissue. So we get things, there's some fibrosis, chronic inflammation, nothing too revealing usually comes from the pathology. But what's interesting is because this is purely a scarring process, that's where the idea of using steroids comes into play. So steroids have been used for scar modulation for decades, primarily in the dermatology literature for the use of keloids. We know corticosteroids can inhibit collagen and extracellular matrix protein production, decrease cytokine production, and inhibit neovascularization. What does this mean? Well, this means it decreases matrix synthesis, it increases action of proteases, and eventually helps to decrease scar tissue. So prior to kind of further intervention, one thing that's really important with these patients is to get an accurate assessment of their disease. In ENT, we do this via nasolaryngoscopy in the office. So we want to see the area of narrowing to get a sense of how severe it is, what level it involves. And so this is actually an example of why visualization is so key. And if we have some of our ENT trainees, hopefully on this call today, this is kind of a point we try to hone in. So same patient, same scope, same office visit, and you can see the difference in the exam. So in the first exam, we can see the larynx with the vocal folds, but really do not appreciate the trachea. So underlying subglottic stenosis cannot be ruled out. In the second image, you can see that the same patient had a ring of scar tissue contributing to symptoms. So how do I do this? Well, I actually do this in the office using transtracheal lidocaine. This is a little video I made. I'll mute it, but I'll show you kind of steps that I take. So I usually use 4% lidocaine on a 23 gauge needle, palpate laryngeal structures and hold the cricoid cartilage stable, then inject below that, kind of entering the trachea at an angle, so you don't back wall into the esophagus, pull back to confirm air, and then a burst of the lidocaine. The patient will cough, but as the patient coughs, this helps to numb the larynx or the voice box. It works in almost immediately, and then I'm able to kind of do the nasolaryngoscopy, and we can turn this view into this one. So passing through the vocal folds, see the cricoid, and see the area of scar tissue. I will mention that this was a patient who had previously been seen by an ear, nose, and throat doctor, but came in for a second opinion for progressive shortness of breath. Another tool that I often use in terms of in the office to manage and follow these patients is in-office force spirometry. So what I'm looking for really with this is peak inspiratory flow and peak expiratory flow. I use it as a quantitative measure as an adjunct to what patients are reporting in terms of their symptoms, as well as what I'm seeing in clinic. We know from basic pulmonary physiology that there are certain patterns that are very consistent with level of narrowing or obstruction. And it's something that can be very incorporated into an office visit. I'll tell you, my patients actually love doing this. It provides them some additional reassurance besides them feeling good or me saying your scar tissue looks about the same. I can tell them, well, look, your peak expiratory flow and inspiratory flow has been stable. So we're going to assume that your disease currently is stable. This also helps me if I start to notice a downtrend. So this is a long-term patient of mine who has idiopathic subglottic stenosis, comes in every 2 to 3 months. We last fall started to notice that there was starting to be a very slight downtrend in her in-office force spirometry, even though she was asymptomatic. So we just preemptively scheduled her for last week. And this really helps from a quality of life perspective because she can plan around it. She knows what's coming. When she starts to feel symptoms, she knows she's already scheduled. And so it kind of helps manage these patients with, again, this chronic progressive inflammatory disease. Another kind of adjunct and things that we're doing to help follow these patients is using patient-reported outcome measures. So we did a quality of life study in our patients with idiopathic subglottic stenosis using common validated quality of life surveys, and we found that there was a high correlation with 6 questions from those surveys. So we've created a separate prompt that we're now currently in the process of validating. Again, this is something patients can even fill out ahead of visits or even at home, and we can track and see if symptoms are worsening. And these are symptoms that are associated or correlate with worsening in-office spirometry. So office intervention. So this is where I talk a little bit about in-office steroid injections. So talking back about kind of how scarring works and how steroids work on scars, the idea was, can we use this for this subglottic stenosis patients? Can we use in-office steroid injections to help modulate scar and decrease return to the office? So current protocol is doing 4 to 6 intralesional injections with a 3-week interval. The way we do this is we use a flexible nasal laryngoscope in order to visualize the subglottis and go through the cricothyroid membrane in order to reach this area. I use the same topical anesthesia that I mentioned earlier, and patients, this is done in the office. Patients go home right after. And what this looks like when we come through is essentially an assistant is holding the camera in place for me, come through the cricothyroid membrane with a double bend in my needle, and inject the scar tissue with the steroid. In patients who have difficult anterior neck anatomy, or if some patients who just can't deal with the thought of needles in the neck, we can do this transnasally as well. So this is using a flexible channeled scope in the office, patient with subglottic stenosis, and then injecting steroids this way. Theoretically, if you were to get an amazing steroid injection and you really kind of filled up the space, there can be a little temporary shortness of breath, but it usually dissipates within 4 hours. Another kind of thing to be careful of with this, especially again for our trainees, transtracheal lidocaine, you really need to hold the cricoid in place, because when patients cough, the trachea will move. If you inject lidocaine outside the trachea, there's a good chance that you're going to temporarily numb the recurrent laryngeal nerve. And so you can get a temporary vocal fold paresis. In a person who has bilateral mobility, that's not that big of an issue. But again, we do the same numbing for other vocal cord injections and things. So technically, if you were to get the opposite side, you could have a patient that develops acute onset stridor in the office. Again, it's rare, but you need to kind of know airway landmarks. We've looked at this, so we've looked at the use of steroid injections, especially for idiopathic subglottic stenosis patients, and we have found that there's generally a decrease in terms of return to the OR and improvement in quality of life with little side effects. So I'm going to wrap up here, but just to kind of summarize, minimally invasive options to management of subglottic stenosis do exist. But the key in terms of if this is an option for a patient really is early identification. And so that's where the high clinical suspicion is for patients presenting with progressive shortness of breath, abnormal PFTs, to kind of get them in so that we can identify this early. Forced spirometry and patient-reported outcome measures can help track disease progression over time, helping to, again, identify these patients when they're having an earlier recurrence. Less scar tissue is a lot easier to work with and open than when it gets grade 3. And then in-office steroid injection can be offered to patients as a management strategy in between needing operative intervention. So thank you.
All right. Tracheal anatomy, 16 to 20 rings, as I was saying, cartilaginous. They're U-shaped rings. They're incomplete, leaving a posterior membranous wall, which is going to be important when we talk about tracheomalacia. So tracheomalacia patients, all patients are characterized by essentially a structural abnormality of their cartilage. That what you end up with is an excessive collapsibility of the cartilage and a reduction in the anterior and posterior diameter. This is most pronounced during expiration. Here you have a normal trachea. Everyone's got a certain degree of protrusion during expiration of their posterior membranous wall. But patients with tracheomalacia have this significantly more pronounced, which leads to a decrease in the diameter of their airway. This becomes clinically significant when the airway decreases by about 50%. You can actually see difficulties with patients with ventilation at this point in time. So when we're talking about tracheomalacia, the crux of the problem is that you basically lose integrity of your airway. So I don't want to spend too much time dwelling on the etiology of this, but it does matter with tracheomalacia because it changes how we treat and manage these patients. So there's 3 broad categories of this. When we talk about tracheomalacia, you talk about congenital, acquired, and extrinsic. So congenital, this is really a pediatric disease with few exceptions, like patients who have underlying cartilaginous diseases like Ehlers-Danlos, but most patients are self-limited. This usually goes away by about 18 to 24 months of age. Acquired and extrinsic are more we talk about in our adult populations. Acquired tracheomalacia accounts for the bulk of what we see with tracheomalacia patients. It's generally caused by some sort of inflammatory process. Tracheobronchitis is the most common cause and is also generally self-limited. COPD makes up 7 to 15% of patients with tracheomalacia, and then other sort of inflammatory causes such as bronchiectasis. Patients with prolonged intubations experience this, both in a diffuse and segmental form, as well as patients after pulmonary surgery can experience this. And then there's a polychondritis is sort of classic for this, although rare as an autoimmune disorder. And extrinsic, you can actually have extrinsic compressions of the trachea, which alter the structural integrity. So aortic aneurysms are classic for this. Patients with enlarged hearts from dilated cardiomyopathies, mediastinal masses, and vascular rings. Surgically and from a procedural standpoint, we usually address acquired and extrinsic disease. Extrinsic disease is maybe easier to manage. You just sort of remove the insulting agent. So if it's an aortic aneurysm causing it, an aneurysm repair will generally fix this. The bulk of this talk is going to be focused on acquired disease. So how do these patients present? One of the things that makes tracheomalacia such a difficult diagnosis to make is that the presentation is fairly nonspecific. Cough, dyspnea, recurrent infections, retained secretions on a bronchoscopy, and eventually stridor. I think we've talked about multiple conditions today where all of these symptoms are present. So it sort of takes a high degree of suspicion and further diagnostic workup to really figure out what is exactly going on with your patient when you see these symptoms. So how do we do that? So when you suspect tracheomalacia, the two sort of stalwarts of diagnosis are dynamic CT scan, which is newer on the block, and then bronchoscopy, which is our gold standard. So both of these modalities involve inspiratory and expiratory maneuvers. So it's really important when you're trying to diagnose tracheomalacia that you're really seeing what happens on dynamic expiration. So meaning you're going to need both of these imaging, whether you're doing a CT scan or you're doing a bronchoscopy. And in this case, you generally want to do an awake bronchoscopy where the patient's able to participate. You're going to ask them to take deep breaths, forceful exhales. And as you can see on both of these imaging, in the last image of the CT scan and during the bronchoscopy, you will see a collapse of that posterior membranous wall. It's important when you're doing your bronchoscopy that you actually start just sort of below the larynx and then move down slowly, measuring out the entire trachea as well as looking into the distal airways. You want to have an idea of whether this is a diffuse process or a focal process, because tracheomalacia can represent both. So if you think you have this, you have a CT scan, you have a bronchoscopy, so who needs to be referred for this? So there is no international classification of symptoms or severity scores specific to tracheomalacia. Some patients have mild symptoms and we'll find this on bronchoscopy, whereas other people are going to have much more severe symptoms. Patients with severe symptoms and acquired disease are who you want to send to a tertiary referral center. Some patients will experience apneic spells, failure to thrive from this, recurrent pneumonias, or cyanotic episodes. These are the patients we really want to see by a multidisciplinary team of pulmonologists and thoracic surgeons. Like I said, for the workup, you want a CT scan. You also want to make sure there's nothing external causing this, your flexible bronchoscopy. And then the next workup, so pulmonary function tests, 6-minute walk tests, performance status evaluations, whether you use a Karnofsky score or some other sort of score. ATS has several dyspnea scores, and then some sort of quality of life score. So in patients with COPD, you might use a St. George questionnaire. You want to use these next tests because to compare your whatever intervention you're going to do, your before and after effects. So what happens when you have a patient who have diagnosed tracheomalacia? So you have two main abilities to treat them. You can stent them, and then there's a surgical approach with a tracheobronchioplasty. I'm going to discuss both. So stents. Stents are the working horse of tracheomalacia. Here pictured is silicone stents. This is what's used in these, both Y stents and straight tubular stents. They're placed under general anesthesia with rigid bronchoscopy. The Y stent itself is favored in these diffuse tracheomalacia cases because it has less migration. Studies done on this actually show that patients who receive a stent have an increase in performance status, their quality of life, according to the St. George questionnaire, and their ATS dyspnea scores even at 2 weeks. Interestingly, 50% of patients with COPD will have significantly improved symptoms also related to their COPD. Complications of stents include obstruction. You can get mucus plugging in them, migration. They can move. They're not anchored by anything other than small straps on the stent. cough. They can be irritating to the airway, and they can cause subglottic edema, which later can cause a stenosis. It needs to be treated. Most patients will undergo a stent trial for 2 to 6 weeks. The problem with stents is these complications actually increase as the stent is in. If you have a patient who's fit for surgical intervention and has a significant improvement of objective scores during stent treatment, that's the patient you want to consider for surgical intervention. Patients who improve minimally with stents will not improve with surgery either. So in a patient who's fit for surgery, who has an excellent response to stents, you want to consider a tracheobronchoplasty. So this is a rather large procedure and should really only be done in specialized centers. The basic surgical principle of a tracheobronchoplasty is stabilization of the airway. It's an extraluminal approach, so nothing is done within the tracheal lumen. You do not violate the trachea, and you actually place a polypropylene mesh along the posterior wall, membranous wall of the trachea to sort of stent that flat, if you will, to prevent that outward collapsing of the trachea. The surgery itself is fairly involved. There are minimally invasive approaches to it, with some centers doing it robotically right now, but most of these are done open currently through thoracotomies. So the complications and postoperative course of a tracheobronchioplasty, it's a relatively high-risk procedure with a 3% overall mortality. Patients, you can tell them to expect to stay in an ICU. Average length of stay is around 7 days in the hospital, and 80% of these patients will discharge to home, with another 20% requiring some sort of rehab facility. The most common postoperative, like almost all thoracic surgical procedures, is pneumonia. However, 90% of these people will report improvement in performance in their quality of life scores. Again, why it's important to document these patients before and after surgery. So sort of in conclusion here, tracheomalacia is a fairly complex disease. Patients really need to be evaluated by a multidisciplinary team with both pulmonary and thoracic surgery. There are viable minimally invasive options such as stenting that exist that really can improve patients' quality of life. And we can expect to see an increase in incidence of this disease with COVID-19. There was a recent article published about 2 months ago in JAMA already looking at an increase in tracheomalacia and tracheal stenosis after the COVID-19. So I think we're going to see more and more of this as time goes on. Thank you.
Well, thanks so much, Dr. Alex and Dr. Hussein. Again, we will be fielding any questions that anyone has. I do have a question for Dr. Hussein as we kick off this session here. So I've had patients before that their stenosis just comes back over and over and over again, and it seems like no matter what we do, they just keep coming back. And then even if we do a tracheal resection, it comes right back after the tracheal resection. Do you know if there's anything that has been shown to predict recurrence? It seems like some patients, especially, and this is just my observation, but some patients, especially young, perhaps female patients, have this increased inflammatory response. Do you know anything that would support that, or any way we could predict who would recur over and over and over again?
So unfortunately, currently we don't have that, but that's part of the research that there's a North American airway collaboration out of Vanderbilt that focuses a lot on subglottic and tracheal stenosis. And so what they're trying to do is classify subtypes of subglottic stenosis, because even within idiopathic, we do see that there are different subtypes. So they're trying to find how to identify those patients early. For patients with really severe disease or disease that we can't keep up with endoscopically, those are the patients we refer for cricotracheal resection. There was a very large paper out from the early 90s out of Mass Gen Thoracic, where they talked about such a high rate of success with tracheal resection. But there's a line in there that mentions the patients that were excluded for study were the idiopathic patients, or the patients with acute inflammation. So that's where we try to use the steroids because we do think it's an inflammatory condition, likely should be treated medically in the future if we can get medication targets as opposed to truly a surgical disease.